In this lesson, we're going to be talking about reducing risk. So, while the long term goal of client counseling is for drug users is to support them to stop using drugs, drug addiction is a chronic relapsing brain disorder. So, it's likely that the clients are going to need to go through multiple episodes of drug treatment before they can remain drug free. So it's critical to provide information about risk reduction to your clients to minimize the possible risks that are associated with drug use. So at the end of this lesson, you should be able to define risk reduction, understand the principles of risk reduction, understand and practice safe injection and safe disposal, know the basics of vein care, and know how to prevent and deal with overdose. Risk reduction can be a policy or a program that's directed toward reducing or containing the adverse health or social and economic consequences of alcohol or other drug use. So it may also be a set of non-judgmental strategies and approaches that aim to provide or enhance the skills, the knowledge, and resources and support that people need to live safer, healthier lives. The design of risk reduction strategies needs to reflect individual and community needs. So, attempts to restrict illicit drug supplies are costly and they produce substantial unintended negative consequences and have rarely produced significant and sustained reductions in drug related problems. The restriction of the drug supply only helps reduce the drug problems when the demand for drugs is low, or detection is difficult to evade, and substitutes are not readily available. This suggests that reducing the supply of drugs will only become a successful strategy for decreasing the harm associated with drug use when effective demand reduction strategies are also implemented. So, HIV prevention strategies for injecting drug users, or IDUs, are developed and implemented in the context of efforts to decrease drug use and meet the health needs of the drug user or any of their other needs, such as primary health needs and human rights. Effective drug education can decrease experimentation with drugs. At the same time, it can also ensure that those who do experiment have the knowledge necessary to prevent the risks associated with drug use, especially HIV transmission. Law enforcement can effectively target major drug suppliers while participating in public health approaches for drug users. So, police forces can play an important role in the prevention of HIV transmission. In some countries, police actively participate in risk reduction by referring drug users for treatment rather than arresting them and even providing them with clean needles and syringes. Imprisoning drug users simply for using drugs doesn't diminish the demand for drugs. It potentially causes major harm to the individual who is often exposed to increased risk in prisons, including a higher risk of HIV infection, while also lacking treatment for their drug problems. Independent of each other, the three different approaches of supply, demand, and risk reduction cannot be regarded as singularly effective. However, together they can complement each other. And that's going to result in favorable environments in which it's possible to contain the problem of illicit drug use and address the HIV/AIDS epidemic among the IDUs. So some examples might be supply reduction in law, policies, crop production, and prisons. Also demand reduction in media campaigns or treatment or school education. And then also in risk reduction, needle, syringe exchange or distribution programs, condoms, peer education, and family support. Risk reduction is one of the most effective tools for addressing the health and social problems related to risky activities. Risk reduction approaches are catered to where clients stand in terms of their drug use, respecting and supporting their ability to make decisions. One of these decisions may be to use drugs or to engage in other high-risk behaviors. People begin to use drugs for many reasons. If you have a client who does not choose abstinence, you, as a care provider, can provide options and support to minimize the negative consequences or the harm that may result. And drug problems occur along a continuum of risk, ranging from minimal to extreme. You can't stop a client from using drugs, but you can help clients reduce the risks associated with their drug use. A risk reduction philosophy allows you to maintain the same level of availability, quality of service, and treatment that you provide to others who may not be using drugs. It means you provide your service without discrimination. So one of the key roles of health and social care providers is to help people live healthier lives. And care providers need to recognize that small improvements in a person's health can pave the path for further reductions of drug use and improve lifestyle. Risk reduction strategies encourage people to build on their strengths and to gain a sense of confidence. They can help someone move from a state of chaos to one of control. So the following principles of risk reduction are adapted from those established by the Canadian Center on Substance Abuse and Linton and Single in 1998. So it needs to be pragmatic. Risk reduction accepts that the use of drugs is common and enduring feature of the human experience. And it acknowledges that while carrying risks, drug use provides the user with benefits that must be taken into account if the responses to drug use are to be effective. Risk reduction recognizes that containment and reduction of drug-related harm is more feasible of an option than efforts to eliminate drug use entirely. It also needs to prioritize goals. Risk reduction responses to drug use incorporate the notion of a hierarchy of goals. The immediate focus is on actively engaging individuals, target groups, and communities to address their most compelling needs through the provision of accessible and user-friendly services. It's essential to achieve the most immediate, realistic goals as a first step toward risk-free use, or, if appropriate, abstinence. And then we need to have humanist values. The drug user's decision to use drugs is accepted. No moral judgment is made either to condemn or support the use. Drug users' dignity and rights are respected, and services endeavor to be user-friendly. Risk reduction approaches also recognize that. For many, drug addiction is a long-term part of their lives, and that responses to drug use must accept that. We also need to focus on risks and harm. So by providing the responses that reduce risk, harm can be reduced or avoided. Risk reduction interventions usually focus on the drug-taking behavior of the drug user. But risk reduction recognizes that people's ability to change their behavior is also influenced by the norms held in common by the drug users and the attitudes and the views of the wider community. So risk reduction interventions may target individuals or communities or even broader populations. But we don't want to focus on abstinence alone. Although risk reduction supports those who seek to moderate or reduce their drug use, it neither excludes nor presumes a treatment goal of abstinence. Risk reduction approaches recognize that short-term abstinence-oriented treatment programs have low success rates, and for opiate users in particular, high post-treatment overdose rates. So we want to maximize the range of intervention options that are available to us. Risk reduction programs help to identify, measure, and assess the relative significance of drug-related harm and balance the cost and benefits in trying to reduce them. Risk reduction strategies can be applied to a range of high-risk behaviors. Examples of risk reduction strategies targeting drug use can include needle syringe programs. So the provision of sterile needles and syringes is a simple, cost-effective way to reduce the risk of spreading HIV and hepatitis C to the population at large. And these programs provide a broad range of services and support beyond the distribution or the exchange provision service. The syringe service provides an excellent mechanism for reaching and providing support to hard-to-reach populations. We also have methadone maintenance programs. Methadone is a synthetic opioid available to people who are addicted to opiates like heroin. It effectively blocks the cravings for heroin without the euphoric effects of heroin. It's relatively safe, non-toxic, and has minimal side effects. And people can be treated safely with methadone for years, and individuals addicted to heroin who are on methadone can live balanced and productive lives. They're able to secure jobs, raise families, and fully participate in their community. Drug replacement programs for other substances are being researched. We also have education and outreach programs. Drug education materials with a risk reduction focus that target at-risk populations can help initiate positive change. And these materials can include information on the safer use of drugs or how to improve overall health. And they can highlight some of the negative consequences of drug use. Outreach workers and other service providers can distribute risk reduction educational materials along with the provision of other services. So sample risk reduction educational materials are included in the risk reduction information kit that I have included in the lesson below. We also have law enforcement policies. Criminalization has long been the general approach toward drug use. And although this is now under public debate throughout the world, there have been shifts towards community policing, public advocacy for access to treatment, and review or revision of legislation, which could allow for the application of more risk reduction measures by enforcement authorities in the future. Intravenous injecting is a highly efficient way to introduce drugs into the body. However, injecting bypasses the filtering and delaying mechanisms that protect us when things are absorbed through the gastrointestinal tract or the lungs or the skin. And this makes injecting the most hazardous way of introducing drugs into the body. Injecting is increasing the potential of infection and overdose as compared to the other routes of administration. So a large body of research shows that injecting is associated with increased levels of drug addiction and increased health risk from blood-borne viruses, bacterial infections, fungal infections, damage to the circulatory system, and an increased likelihood of overdose. And although the best way of reducing the harm associated with injecting is not to inject, it's clear that many IDUs don't want to stop, and they tend to evade interventions and treatments that primarily seek to stop them from injecting. IDU services have to provide appropriate information and support on how to reduce a range of injection-related risks. Most information and advice for drug users focuses on preventing the sharing of needles and the transmission of blood-borne viruses like hepatitis B and C and HIV. However, many injecting drug users experience injection site problems such as infections and physical damage, and most don't seek appropriate treatment for them unless they become serious. And this is going to result in greater levels of permanent damage and the injecting drug user requiring more intensive and expensive treatment. So it's important that counselors are able to give advice to reduce the incidence of problems at the injecting sites and to encourage appropriate help seeking when they do occur. Although it would be desirable to have staff with nursing or medical expertise available within all counseling facilities, that's not practical for many services. But provided they have the knowledge and the confidence, counselors can provide clear and useful advice on preventing and responding to local injuries and infections, and on ways of reducing injecting damage. So there's 3 types of injections. The injection penetrates just under the skin. If it penetrates just under the skin, it's called subcutaneous. And if it goes deeper into the muscle, we call it intramuscular. But most injecting drug users who use illegal drugs prefer to inject directly into the vein, which is called intravenous injection. It's easier to inject into a vein if the bevel is facing upward and the needle is introduced into the skin at about a 20-degree angle. This makes it easier for the needle to penetrate the skin and enter the vein. When the needle is in the vein, you need to be able to see blood at the base of the barrel of the syringe. Arteries take oxygenated blood from the lungs to the rest of the body. They progressively branch out, diminishing in size until they reach the capillaries. The blood then passes through the capillaries and the tissues, releasing its oxygen, and is collected in small veins, which, by joining together, progressively increase in size. The veins return deoxygenated blood to the lungs after it's passed through the heart. Accordingly, all drugs injected into veins must follow a route back through veins of increasing size to the heart. From the heart, the drugs are pumped the short distance to the lungs, where the blood passes through the capillaries of the lungs to be reoxygenated. The oxygenated blood then returns to the heart to be pumped to the brain and other body tissues. And when a drug is injected into a vein, it reaches the brain via the lungs in a short time, which is about 15 to 20 seconds. The drug is not significantly diluted, hence the experience of the rush or the hit as the brain rapidly becomes intoxicated. Valves are only present in the veins and assist the flow of blood back to the heart by preventing backflow. We can see this on the slide here. Arterial injection. All the injecting drug users should be warned that they should never inject into a blood vessel in which they can feel a pulse. It's very dangerous to inject into arteries, and it can be potentially lethal. Although most arterial injections are accidental, occasionally people attempt arterial injection deliberately. The practice of deliberate arterial injection should be strongly discouraged. For drug users who hit an artery by mistake or otherwise, your advice should be to withdraw the needle immediately. Do not complete the injection. Put strong pressure on the site for at least 15 minutes. Raise the affected limb if possible and seek medical advice. So why is it so dangerous to inject into an artery? Air injected into an artery can block blood flow and kill you. Extreme blood loss can occur. The blood in arteries is under high pressure. Artery spasm can cause the limb to die, and it can cause extreme pain. Blood clots form when there's turbulence in the blood flow. Damage to or inflammation of the lining of the vein can trigger blood clots at the site of the injection. These clots stick to the lining of the vein, and they're known as thrombus. These clots themselves cause turbulence. The turbulence can cause further clotting, and a blood clot inside a vein does the same thing as a blood clot on the surface. It hardens and it turns to scar tissue that shrinks and pulls the edges together. It's this pulling together of the edges that makes the veins, quote unquote, collapse. So veins have collapsed in this way do not unblock. The blood has to find another way back to the heart. Veins may become temporary blocked if the internal lining of the vein swells in response to repeated injury or irritation. This can be caused by the needle, or by the substance injected, or by both. And once the swelling subsides, the circulation will often reestablish itself. Smaller veins may block as a consequence of too much suction when the blood user pulls back against the plunger of the syringe to check that the needle is in the vein. This will pull the sides of the veins together, especially if they're inflamed, and the sides of the vein may stick together, causing the vein to block. Removing the needle too quickly after injecting can have a similar effect. Permanent vein collapse can occur after either long-term injecting, repeated injections, especially with blunt needles, poor injecting techniques, or injecting of substances that irritate the veins. This diagram identifies a range of injecting sites that are commonly used by injecting drug users. Veins in the upper arm and forearm are okay, but they should be rotated. Veins in the hands, groin, and armpits are potentially dangerous because of their proximity to major arteries that the drug user could inject into by mistake. Drug users should be advised never to inject below the waist, as there's a greater risk of injecting into arteries. A number of problems can arise when the flow of blood through the limbs has been severely affected. These include ulcers, which are broken down skin, abscesses, which are localized areas of pus within inflamed tissue, phlebitis, which is an irritation of the vein's smooth inner lining, cellulitis, which is a painful inflammation of the skin, and gangrene, which is death of body tissue. So with ulcers, one possible result of the serious deterioration of circulation can be painful areas of broken down skin, which is what we call ulcers. Ulcers form when the skin is knocked or scratched or injected into and the surface is broken. The slow flow of blood means that the cells cannot produce quickly enough to heal the wound. The resulting moist and painful wound can take years to heal and can be compounded by infection. An infected abscess is a localized collection of pus that's encapsulated within an inflamed tissue. It can be caused by a wide range of bacterial and fungal infections. An abscess is different from cellulitis in that it has a defined edge and space. So an abscess is characterized by raised skin surface, localized heat, tenderness and pain, redness of the skin, particularly in white people, a pus formation, and a foul smell if it has begun to discharge. People with abscesses should be referred for medical advice and treatment. The abscesses will require antibiotic treatment or lancing to release the pus. Injecting drug users should never be told to try to lance or puncture the abscesses themselves, because this can spread the infection, and without appropriate antibiotics, they can quickly develop septicemia, which is blood poisoning. They should be encouraged to alternate injection sites, as this will lessen the risk of localized inflammation or infection and abscess formation. Phlebitis is an irritation of the smooth inner lining of the vein, making it rougher. The roughening of the vein lining can encourage the formation of clots. The vein is reddened or inflamed and can sometimes be felt as a thick cord beneath the skin. Phlebitis can occur as a result of injecting irritant substances such as pills, or poor injecting techniques, infections, or accidental injury like knocks or blows to the site. An important complication of phlebitis is deep vein thrombosis, or DVT, which can lead to pulmonary embolism. If phlebitis is suspected, the person should be referred for immediate medical advice. Treatment includes resting and raising the limb, antibiotics, and anti-inflammatory drugs. Cellulitis refers to a painful spreading inflammation of the skin, which appears red and swollen with fluids, and we call this edema. Cellulitis can occur as a result of irritant substances lodged in body tissues or serious infection. So when cellulitis is suspected, the client should be referred for immediate medical advice. Treatment is going to include resting and raising the affected limb and treatment with antibiotics and anti-inflammatory drugs. People who have had cellulitis should take a couple of steps to prevent it in the future. like using sterile injecting equipment, using sterile water where available, and discussing alternatives where it's not. They can avoid the injection of irritating or heavily adulterated drugs, or remove rings prior to injecting if they're injecting in the hands. And lastly, gangrene is the death of body tissue caused by impaired or absent blood supply. So gangrene can occur as a result of serious damage to the veins or arteries. The effects of gangrene can be disastrous, and it can lead to the loss of limbs. And it can also cause the products of tissue to breaking down when they're entering the bloodstream, causing blood poisoning. So gangrene can be life-threatening. Simple vein care methods can prevent vein damage, so be sure to train your clients to follow a few steps in vein care. We want to teach them to use a new sterile needle and syringe every time. Use the smallest needle size, which is about 27G. Clean the injection site before injection. Go slow and be gentle. Rotate sites of injection. Learn to inject in both arms. Don't inject where there is redness, swelling, or pain. Never inject pills. And ensure that you maintain a healthy diet and adequate sleep. This is a typical track mark due to intravenous heroin use. This person, their track mark is in their arm. It's a slight inflammation, which is a red line up the arm. This is thrombophlebitis, an inflammation of the vein. This slide shows extensive track marks and also thrombophlebitis from their intravenous drug use. This slide shows infection from intravenous drug use. The client's been treated for 1 week on antibiotics, but the site still shows an open lesion and cellulitis. This slide shows a venous abscess from intravenous drug use. Infections may also include septicemia, referring to the presence of pathogenic organisms in the bloodstream that lead to sepsis, or a septic joint in intravenous drug users. Hot, painful joints should be assumed to be septicemia until proven otherwise. Now let's talk about overdose. Overdose is now the leading cause of death among injecting heroin users. Taking heroin when intoxicated with other depressants that act on the central nervous system, such as alcohol or benzodiazepines, can enhance the toxicity of the heroin and cause a fatal overdose. So let's talk about the main things that cause overdose. They're going to include injecting drugs. Injecting heroin users are about 14 times more likely to die than the general population. People who inject heroin are much more likely to overdose than people who smoke it. Also, mixing drugs and alcohol. Most overdoses happen when people have alcohol or other downers like Valium or temazepam in their system when they inject heroin. And these sedative drugs combine to depress the central nervous system and breathing. And people can literally just stop breathing. Also, when using opioids, or if the person is using opioids when the tolerance is low, it only takes a few days for a drug user's opiate tolerance to drop. After a week or so without opiates, a dose that wouldn't have had much of an effect on you at one time can kill you. So people who have often overdosed before and survived can still die from an overdose. It's not normally new users who overdose. It's usually people who have been injecting for years. Sometimes overdoses are not accidental. People feel depressed or hopeless or not caring whether they live or die. They all make overdose more likely. Talking about your feelings is important, and it can help reduce the risk of non-accidental overdoses. Some of the risks of overdose are not knowing the quality of the drugs, not knowing the body tolerance, mixing drugs or using alone with nobody to rescue you, and more importantly, knowing what other substances are in the drugs. There's been a lot of users who have accidentally overdosed because they didn't realize that fentanyl or carfentanil or iso or xylazine were in the drug that they were using. If someone has overdosed, put them in the recovery position, which is on their side, with one knee kind of bent a little bit to keep them from rolling, and one arm out to keep them from rolling. And keep watching them. You need to know if they're unconscious. You can figure this out by rubbing your knuckles on their sternum, which is the center of their rib cage. Other signs include if you can't wake the patient or if they show other signs of unconsciousness like snoring deeply, turning blue, or not breathing. In the event of an overdose, please remember to stay calm. If the person is not breathing, provide rescue breathing. If the person has no breathing and no pulse, provide chest compressions and rescue breathing. If the person has both breathing and pulse, then maintain them in the recovery position and protect them from choking on their own vomit. We can use the ABC approach, which involves checking on the airways, breathing, and circulation. So open the airways by lifting the chin up and tilting the head back. You want to open the mouth. If it's blocked by anything, including vomit, tilt the head to one side and clear the mouth. Put your ear by the person's mouth and look down the length of the body. Take no more than 10 seconds to look, listen, and feel for signs of breathing. Then look for signs of circulation, such as breathing, coughing, or movement. Take no more than 10 seconds. Cardiopulmonary resuscitation, or CPR, is a technique of rescue breathing combined with chest compressions. The purpose of CPR is to maintain sufficient circulation to preserve brain function until specialized treatment is available. Rescuers should start CPR if the victim has no signs of life, such as being unconscious, unresponsive, not moving, and not breathing normally. There should be 30 compressions of the chest, followed by 2 ventilations. The compression rate should be about 100 to 130 compressions per minute. If this is combined with 2 breaths, each given over 1 second per inspiration, there should be 5 cycles, approximately 2 minutes. Then check if the person is breathing and or has a pulse. If not, repeat the cycle again. The following are steps that you should take to place somebody into the recovery position. Make sure that there are no foreign objects in the mouth, like loose dentures or vomit, by looking in the mouth and removing any obstructions. Open the airway by tilting the head back and lifting the chin. Straighten the legs. Place the arm nearest to you at right angles to the body. Pull the arm furthest away from you across the chest. Hold the leg furthest from you above the knee and move it upward across the leg. Ensure the back of the hand is placed against the cheek nearest to you. Keep the hand pressed against the cheek and pull on the upper leg to roll the patient toward you and onto his side or her side. Tilt the patient's head back to ensure that they can breathe easily. Ensure the hip and knee of the upper leg are bent at right angles. So you can see kind of how the person should be placed in the recovery position in position 4 on this slide. There are a few things that you should never do during an emergency overdose. Don't walk people around. This can make things worse because there's a risk that they might fall and hurt themselves. And it's also possible that the heartbeat increases with exercise. The drugs are going to be absorbed into the bloodstream more quickly. Don't put people in cold baths to wake them up. If you've ever heard of people who woke up when they were put in a bath, it was because they were lucky and had not taken a lethal dose. It was not because they were put in the bath. Putting people in a bath is dangerous because it takes time to run the bath and they could die while it's filling. Even if they are alive, when they're put in it, they could easily drown or die of hypothermia. And don't hurt, hit, or burn people to bring them around. You do need to know if somebody is sleeping or unconscious, and you can tell this by rubbing your knuckles on the middle of their chest. If this doesn't wake them, they are unconscious and you need to call an ambulance and start first aid. Anything more drastic could cause them serious injury. Don't inject people with salt water either. The idea of injecting people with salt water might have come from people seeing friends in hospital be given a saline salt drip and think that was part of the cure. In fact, the drip is put in to keep a vein open so medical workers can inject medication. Injecting salt water is dangerous because it wastes valuable time, and if the salt water is given in a used syringe, it could give him HIV or hepatitis. So, some tips for preventing overdose are to have an overdose plan with the people you get high with. Be careful if you switch dealers. There are test strips available to find out if there's fentanyl in the drug supply that you're getting. Ask around. Drug strength will vary. Prepare your own doses or drugs so you know how strong you've made them and exactly what's in them. Avoid mixing heroin with other drugs and avoid shooting up alone. So, in summary, risk reduction provides an alternative approach and framework to deal with IDU problems. Risk reduction principles have been adopted in a number of countries, and they've been shown to be pragmatic, humane, effective, and holistic. And risk reduction is a public health approach that assists in the control of HIV infection among IDUs. Risk reduction is supported with the current scientific evidence, and it has demonstrated remarkable achievements. An increasing number of countries are adopting risk reduction principles because they've been shown to be pragmatic, humane, effective, and holistic. I want to thank you for attending this training. If you have any questions or comments, please put them in the comments section below. Also, please be sure to pass all of the quizzes in each of the lessons with a 70 or more before you can receive your certificate. Once you have completed all requirements for each course, you will be automatically generated a certificate for this particular course. Please be sure to check out our other course offerings back on the home screen.